Yes, start Dr. Saikant.
Good evening to one and all. I first of all thank you, Dr. Sharma sir, for giving this opportunity. And today my topic is on ticagrelor, and I will be dealing this topic under these headings. So about the introduction, on this present era of increasing strokes and advanced treatments for stroke, the risk of major stroke ranges from 3 to 15% in the first 90 days after a minor ischemic stroke or a transient ischemic attack. A lot of trials were happening which has proved that aspirin has been shown to reduce the risk of recurrent stroke by approximately 20%. The present guidelines of dual antiplatelet treatment for this kind of transient ischemic attack or minor ischemic stroke is clopidogrel plus aspirin combination, which has proven to be more effective. However, clopidogrel efficacy is uncertain and is inefficient in 25% of white and 60% of Asian population because of their gene structure, which was proven in the recent studies and in our experience as per our agrometry assays. This resulted in lot of controversy and lot of trials has been conducted. The most recent trial, that's TAILS trial, which showed where the ticagrelor along with aspirin effect was assessed, and which has proven to be more efficient, and the relative risk reduction of stroke or death has been reduced for up to 17%. With this introduction, let us go into the main topic. There are a lot of antiplatelet agents. The present classification, which includes aspirin, which is a major drug in antiplatelet agent, which belongs to cyclooxygenase inhibitors. Clopidogrel, prasugrel, and ticlopidin are thyroperidine group of adenosine receptor inhibitors, whereas Vorapaxar is a platelet activating receptor antagonist. Silostazole is phosphodiesterase inhibitor. Riopro integralin agrastat is GP2B3A receptor inhibitor. Dipyrimidol is adenosine reuptake inhibitor. Our drug ticagrelor is a newer one which belongs to cyclopentyl triazolopyrimidine group of ADP receptor antagonist, and its chemical structure is almost similar to that of a ATP. So how this drug has been came into use? This is a structure of ATP. ATP itself is a known ADP receptor antagonist. Because of its low potency and short acting nature, ATP is not used as an ADP receptor antagonist. So all researchers has searched for a more stable compound, which resulted in discovery of a newer drug called cangrelor, which is slight alteration in the chemical structure of the ATP. Even though cangrelor was discovered, this is also a short acting drug, and it is given through IV. So in order to get more stable and sustainable alternative of cangrelor, they have further altered the chemical structure, which resulted in uh, discovery of a compound called ARC109318XX, which is a first selective and stable non-phosphate P2 white well antagonist. This is also a stable compound, and in order to make it more sustainable and orally available, resulted in the discovery of a more stable product, which is ticagrelor, and this is the most stable orally available P2 white well antagonist which is available in the market right now. So what is the mechanism of action? Before going to mechanism of action, just a small glimpse about how the clotting happens and thrombus formation happens. For any thrombus to form, first there should be a rupture of an atherosclerotic plaque exposing the collagen and von Willebrand factor. This von Willebrand factor binds with its A1 domain to the platelet GP1B receptor on the platelet surface. This initial binding is followed by further platelet recruitment and platelet activation and release of ADP. ADP binds to P2Y12 receptor on the platelets, and which will amplify the platelet recruitment. So this is a small image which is showing the mechanism of thrombus formation. So there is a disturbance in the endothelial surface resulting in exposure of the collagen and von Willebrand factor. This results in the platelet attraction towards this von Willebrand factor. The von Willebrand factor just attaches to the GP1A receptor, and it forms a platelet plug. And further releases an important compound called ADP. This ADP is having more affinity towards P2Y12 receptor on different platelets, and results in activation of these platelets. Our ticagrelor, which we are discussing about, acts on this pathway and avoids this ADP receptors to get attracted towards this ADP. So the ticagrelor is a orally available reversible compound. It binds non-competitively to the P2Y12 receptor at a site distinct from that of an endogenous ADP. In contrast to other thienopyridine groups such as prasugrel and clopidogrel. The main difference between the clopidogrel, prasugrel and ticagrelor is its reversible nature. These clopidogrel and prasugrel, once bind to these P2Y12 receptors, it will deactivate the platelets for its life. Whereas this this ticagrelor is having a reversible nature, which is the main component of this ticagrelor. So coming to the pharmacokinetics, it is an orally available drug and it is rapidly absorbed. After absorption, it is highly bound to plasma proteins and largely restricted to plasma space. The Tmax of ticagrelor is nearly 2 to 3 hours. And because of its reversible nature, it can be eliminated from the bloodstream after a certain time after the cessation of the drug. This ticagrelor is not a prodrug, unlike any other clopidogrel or prasugrel, and does not require any metabolic activation for antiplatelet activity. Ticagrelor is predominantly metabolized by cytochrome P450, that is CYP3A4 and C3A5, to an active metabolite ARC124910XX. The mean elimination half-life of ticagrelor is 6.7 to 9.1 hours. And the half-life, as I already told, it is around 6 to 12 hours. Once it is taken, it will achieve steady state in 2 to 3 days. The time to peak platelet inhibition will start within 2 hours, and the maximum platelet inhibition is 90 to 95%. This ticagrelor is not excreted by the renal. So in case of a severe renal impairment, it does not significantly affect the pharmacokinetics, pharmacodynamics, or safety. Whereas the usage of ticagrelor is not advisable in moderate to severely hepatic failure patients as per the guidelines. It can be given for mild hepatic failure patients. The present dosing dosage for dosing and administration of ticagrelor in case of an acute event or a TIA is loading dose of 180 milligrams followed by maintenance dose of 90 milligrams twice daily. This helps in sustaining the drug and platelet and achieving maximum platelet inhibition. Coming to the drug interactions. These ticagrelor is, as I told earlier, it is predominantly metabolized by CYP450, predominantly 3A4, and lesser extent to by 3A5. So whichever drugs which are inhibitors of CYP3A4 will increase exposure of ticagrelor, and their combined use is not recommended. So what are the drugs which will cause strong CYP3A inhibiting ability? These are few drugs like antifungals like ketoconazole, itraconazole, and voriconazole, antibacterial, clarithromycin, telithromycin, and serotonin antagonists and reuptake inhibitors, nefazodone, and antiretroviral drugs like ritonavir, saquinavir, nelfinavir, indinavir, and atazanavir. These drugs are strong CYP3A inhibitors. So the exposure of the metabolism of brillianta is delayed and results in more plasma concentration, and there is chances of bleeding bleeding tendencies in patients. So mostly should be avoided in combination with these drugs. Coming to the strong CYP3A inducers, these inducers will reduce ticagrelor exposure because this will increase the activity of CYP3A by further washing of the ticagrelor fast. Anti-TB drugs like rifampin, other drugs like dexamethasone, anti-epileptics like phenytoin, carbamazepine, phenobarbital are strong CYP3A inducers. Next, the opioids. These opioids like codeine and morphine, co-administration of opioid agonists delay and reduce the absorption of ticagrelor, further elevating the chance of bleeding. And aspirin can be given with brillianta, but below the 100 milligrams, because this aspirin will have a dose dependent action on along with brillianta, resulting in increase effect of brillianta and bleeding tendencies if we give aspirin above 100 milligrams. So simvastatin and lovastatin are the other drugs which will increase serum concentration of brillianta, because these are the drugs metabolized by CYP3A4, and it has to be in consideration when we are giving brillianta along with simvastatin and lovastatin. It should not go beyond 40 milligrams. Digoxin, ticagrelor inhibits the P-glycoprotein transporter, which is a major thing in digoxin metabolism, resulting in increased digoxin levels. So should be avoided in patients with bradycardia and sick sinus syndrome. So digoxin and ticagrelor should not be given in patients with bradycardia as well as some cardiac symptoms like sick sinus syndrome. There is other grapefruit juice. These are not having much of studies, but this has shown to increase ticagrelor exposure, and there is a tendency of bleeding in patients who are taking grapefruit juice twice or thrice daily along with ticagrelor. So coming to the safety, with lot of trials have been done on ticagrelor along with other antiplatelet agents. Most of the adverse actions and other problems related to ticagrelor are bleeding, dyspnea, increase in ventricular passes. Bleeding is as expected because of the P2Y12 receptor inhibition. There is a high tendency of bleeding. Dyspnea and ventricular, there is an increase in ventricular passes in patients who are taking brillianta. The mechanism of action is its ability to delay adenosine metabolism. We already know that brillianta is having a similar chemical structure as that of ATP, and ticagrelor increases adenosine concentrations through inhibition of adenosine uptake by erythrocytes by inhibiting ENT1, which is a predominant transporter which will allow the adenosine to be taken by the erythrocytes. Because of this thing, there will be an elevated ventricular passes as well as dyspnea, and there is a high chance of increase in uric acid because of the breakage of the ATP structure, And there is an also a hypothesis saying that there will be elevated creatinine because of the adenosine, which is getting released because of the brillianta. So coming to the clinical trials, there are a lot of clinical trials were performed in which most of them are in cardiac related to the cardiology. First trial which was performed was a disperse trial, a phase 2 trial, which is used to assess the pharmacokinetics, pharmacodynamics, and safety profile of ticagrelor. Assessing in this thing, they have found out that platelet inhibition was greater with ticagrelor when compared to clopidogrel. This study was was performed in a stable patients where clopidogrel along with clopidogrel and ticagrelor both were given in two different sets, and they found out that ticagrelor has resulted in a greater platelet inhibition when compared to clopidogrel. The another trial which was done next to disperse was disperse 2 trial, where the clopidogrel loading dose was 300 milligrams and ticagrelor was 90 mg or 180 mg for up to 3 months. The same results were shown in disperse 2 trial also, but they have told that there is chances slight risk of bleeding when compared to disperse 1, probably because of the loading doses of brillianta. Next one is the response trial. This is also a phase 2 trial where they have checked the patient's response to ticagrelor in clopidogrel non-responders. They found that the response to ticagrelor in clopidogrel non-responders was very good, and ticagrelor is very good in bringing the complete platelet inhibition when compared to clopidogrel in clopidogrel non-responders. The other trial is onset and offset trial, where the onset of platelet inhibition and offset of platelet inhibition were assessed between clopidogrel and ticagrelor. This also has proven that the onset of platelet inhibition is much smoother and steadier with ticagrelor, and the offset is also faster than clopidogrel because of its reversible nature. So the most important trial is the plateau trial, where they have assess the efficacy between clopidogrel and ticagrelor along with the aspirin. In this, the efficacy endpoints, if you see this blue thing is the clopidogrel and ticagrelor is the green one. The efficacy endpoints are much better for ticagrelor than the clopidogrel, but the safety and endpoints, if you see, not much difference. Only the significant difference is seen in this dyspnea and ventricular passes, and they say that CABG related major bleeding is also high in ticagrelor group because of the higher efficacy like P2Y12 receptor inhibition. Next important trials are two important trials, which is one is chance trial. This is chance trial, which is a large trial done by Chinese, and they have found out that dual antiplatelet treatment, clopidogrel plus aspirin, followed by maintenance doses of 75 mg of clopidogrel and 75 mg of aspirin during the first 21 or 90 days after TIA or minor ischemic stroke, reduce the risk of stroke, myocardial infarction, and vascular death by approximately 30% as compared with aspirin alone, mainly within the first 21 days. These two trials are predominantly clopidogrel and aspirin based trials. These are the trials which were predominantly done in neurology group to assess the efficacy of dual antiplatelets on minor stroke and transient ischemic stroke. This is a point trial where they have assessed the high risk TIAs by giving a higher loading dose of clopidogrel. They have found that both has significantly reduced the chance of further strokes in the next coming 90 days, but there is a high chance of bleeding in the second point trial because of elevated loading dose of clopidogrel. This resulted in the comparison between ticagrelor versus aspirin in acute stroke or transient ischemic attack. This is the Socrates trial. They also found that when ticagrelor was given alone without any other aspirin or clopidogrel, and the efficacy of ticagrelor over aspirin was assessed in this trial. They have found out that ticagrelor is not superior to aspirin in treating acute stroke, and it can't be given in a as a single drug for treatment of acute stroke or transient ischemic attack. The recent trial, which is a Thales trial, showed that ticagrelor plus aspirin resulted in 17% relative risk reduction of stroke or death compared with placebo added to aspirin alone. This is a major trial where they have compared the efficacy of ticagrelor along with aspirin and placebo with aspirin. Ticagrelor was given as a loading dose of 180 mg followed by 90 mg BD dose, and along with aspirin 75 mg. And they have given aspirin alone with a placebo. They found that there is a significant inhibition of platelets, and the number needed to treat was 92 to avoid one stroke or death at the day 30. So with this, I have to conclude that the recent AHA guidelines still now following the dual antiplatelet treatment, where the aspirin and clopidogrel were given. And in our practice, where we actually do the stenting for intracranial atherosclerotic disease, we used to treat the we started testing the patient with agrometry, where most of the patients has proven clopidogrel resistance. So we have changed our practice from giving clopidogrel as a loading dose to Brillianta, and which is showing very good results, and there is a absolutely very minimal risk of bleeding even if we are using Brillianta as a loading dose, less chances of intracerebral hemorrhage, and less bleeding complications. So to conclude, inhibiting the P2Y12 receptor, platelet receptor, has demonstrated an ability to reduce adverse cardiovascular outcomes significantly over the use of aspirin alone. Despite over a decade of use with clopidogrel, the agent has number of limitations that need to be addressed. Ticagrelor is a P2Y12 receptor inhibitor that overcomes many of these limitations, like clopidogrel non-sensitivity. So this I conclude. If sure, Sharma sir.